Early identification of sepsis is really of paramount importance. And we have all known some cases where the patient was there for a while before we were called, before anybody realized that this patient needed immediate attention for sepsis. So we need to train and inform our colleagues, not only in the intensive care unit, but in the emergency department and anywhere in the hospital, on the regular floors of the hospital. I'm not so sure that we can improve the situation outside the hospital because actually the doctors will send to the hospital, I suppose, patients who look bad. But in the emergency department already, sometimes doctors who take care of these patients do not realize that the situation is really severe. They may send some of these patients back home when they should be hospitalized in an intensive care unit. So what should we tell them? Well, in some cases, it starts with the fever, with the infection, and then we can look for the organ dysfunction associated with it. But sometimes it's the other way around. The patient presents with circulatory failure or signs of organ dysfunction that are not well explained, and this may be sepsis. That's very important because it is in the latter case that people sometimes forget to give antibiotics and give fluids and give vasopressors if needed, and in one word, to call for specialized people from the intensive care unit. So, what are these signs of organ dysfunction? There are 6. Cardiovascular, of course, and cardiovascular dysfunction is associated with signs of altered tissue perfusion. Let's look at the skin perfusion. Is the patient vasoconstricted? How is the capillary reperfusion when I examine the fingers? What is the mental status? Some patients may become disoriented or confused when they were not like that before. So it's not necessarily coma. It's more altered mentation that was not present before. And decreased urine output. Of course, it's not always easy to see it in the emergency department. Of course, we need to have a urinary catheter in place and follow the diuresis over half an hour or 1 hour to diagnose it, of course. But if we have it, we should really look at it as well. These are what we call the 3 windows of acute circulatory failure. And these alterations are typically associated with some degree of hypotension, but hypotension sometimes is not so evident, especially in patients with a prior history of hypertension. They may be somewhat normotensive, and this is abnormal for them. Don't forget to measure lactate levels in these patients. Don't tell me that it cannot be measured in your hospital. It can be measured anywhere in the world because lactate analyzers are cheap. They can be found for a low price everywhere. If it's not available in your hospital, go to the management, go to the lab and tell them that they need to provide you with such an instrument. You can quote me on this. It's really the basic quality of care. And we will have to repeat the lactate measurements every hour in patients who seem to be in trouble. So this is true in the emergency department or on the regular floor of the hospital. So we need to tell our colleagues, cardiologists, pneumologists, OBGYNs, dermatologists, whoever works in a hospital, and also nurses and other people working in a hospital, because anybody could identify the patient who doesn't look good, who may become disoriented, who may be hypoperfused, who may be hypotensive. They need to call, and we must then start infection control, hemodynamic stabilization on an emergency basis. So on the floor, perhaps we could use an alarm signal. With our consensus discussions last year now, we propose to use a Q SOFA. A Q SOFA reflecting the three elements that could be alarm signals: hypotension, tachypnea, reflecting respiratory component, and the encephalopathy, the altered mental status, as I say, disoriented confusion. If there is any of these three elements which are not well explained, people should call for help, and this should result in a rapid evaluation of the patient. So, sorry, when I mentioned the 6 organs, I started with the cardiovascular dysfunction, but I already mentioned the respiratory system, tachypnea, or hypoxemia. If we have a pulse oximeter in place, if there is hypoxemia, that could be indeed a sign of respiratory involvement. The third element is neuro. We mentioned the obtundation, disorientation, confusion. The fourth element is the kidney that we also mentioned, oliguria primarily. The fifth element is the low platelet count. It may not be readily available, but if we see in the lab tests that a patient has a low platelet count, and if we do not know why, it may be sepsis. Nothing here is specific, but it may be that. And the sixth element is the increased bilirubin level in a patient without biliary tract problem. Patient is getting yellow, bilirubin levels increase in the blood. We don't know why. We do an echo of the liver, the biliary tract, nothing wrong. That's liver dysfunction. Not liver failure. No. It's an alteration in the liver tests that may be due to sepsis. So the 6 elements: cardiovascular, respiratory, neuro, renal, hematologic, liver. The order doesn't matter. The 6 organs matter. Everybody working in a hospital should know these 6 elements. Ask them around you. Make sure that they know about it. Make sure that the medical students heard about it, because it avoids confusion. It can add some good process in your mind when you go over this checklist. And indeed, the nurses should also participate in this process, because sepsis management should start early, promptly, and effectively. And for this, we need to identify the septic patient quite rapidly.